So maybe now for something slightly different, but what I wanted to briefly say at the beginning is that what we see in general vascular anomalies around the body can sometimes occur and sometimes have their equivalent type of lesions in the liver. So, for example, this infantile hemangioma we see in the face of this baby can occur in the liver. This Riche lesion, which I showed you an angiogram on the chest wall, can occur in the liver. These venous malformations can occur in the liver. In fact, in adult practice, what we now recognize is most of the so-called hemangiomas that we see in adults, and I'm not an adult radiologist actually, but what my adult colleagues tell me, we believe actually are malformations, not hemangiomas in adulthood, because infantile hemangiomas are a disorder of babies and infants. You can get lymphatic malformations involving the liver, and of course arteriovenous malformations. So the whole array, virtually, not quite, but nearly all, the whole array can actually express itself in the liver, causing a variety of problems. And so I've got a few examples of all of these actually to illustrate, which won't take too long this afternoon before we see the cases that Matthew has from this week. So when we look at the liver, we still use this classification by the International Society of Vascular Anomalies. It's still very important for us to try and categorize these lesions. And the lesions that we're looking at, as I said, in the liver were maybe infantile hemangiomas, the Riche type of congenital hemangioma, venous, lymphatic, AVMs, and fistulas that we see. So when we're dealing with pediatric vascular anomalies in the liver, the important thing, like vascular anomalies generally, is to have a good clinical understanding, and importantly for us as interventionists, understand what does that child have in relation to the anomaly, what problems is that anomaly giving the child in the liver. Is the child in cardiac failure because of shunting? Shunting doesn't just mean AVM, shunting can occur in infantile hemangiomas. The children can be critically ill and nearly dead with infantile hemangiomas that are shunting. And really what we want to know is sometimes some of the children have GI bleeding. These can be due sometimes to arterioportal fistulas. We've really got to ask ourselves, is treatment really required? We see many, many children with children who've got hepatic infantile hemangiomas, which are small, are often incidental findings, and we need do nothing about these, because infantile multifocal hemangiomas in the liver, if they're not causing a functional disturbance, can be left alone, and they will follow the natural three-phase life cycle as infantile hemangiomas do elsewhere. They'll proliferate, involute, and then become involuted eventually after many years. We need to always have a goal. If we've got a child in cardiac failure, then our goal is to try and actually get this child out of cardiac failure, and decide how are we going to treat some of these conditions, if we need to treat them at all. Is our goal maybe just to close the feeding channels and the shunt? Our approach, should it be arterial? Does it need to be femoral, brachial, directly transhepatic through the portal vein, or retrogradely through the hepatic vein, perhaps from a jugular approach? And define the endpoint of any of the procedures that we do, and understand that many of these procedures may have to be staged. They may have to be staged because of our limitations with contrast that we can give a child. Usually we follow a rule of no more than 6 mils of iodinated contrast per kilogram of body weight at any one sitting, but we do vary slightly. When we're accessing small vessels, we also liberally use nitroglycerine in those channels as well, and have nitroglycerine paste available after we finished. We make sure that the children, if we're dealing with AVMs in the liver, when we're embolizing them, and hemangiomas, they get antibiotic prophylaxis. We actually give AVM embolization patients steroids, as we would if we were dealing with AVMs outside the liver in the periphery. Actually mention about giving steroids actually when we treat by sclerotherapy venous and lymphatic malformations and AVMs, we just use a one-dose steroid at the time of the procedure, and we give 0.1 milligrams per kilogram of body weight, up to a maximum of 8 milligrams if the child obviously weighs, for example, 80 kilograms. And we do have children in Canada who weigh 80 kilograms. So we need to have some basic understandings, and then we can proceed if we need to. So the hepatic vascular anomalies predominantly affect the younger age group in my practice, particularly babies actually. The fistulas, the arterioportal fistulas, can be seen in older ages, but also in babies. But it's the infantile hemangiomas that we see that can be problematic, and they can be problematic usually in the first few months of life. And the neonatal AVMs, the AVMs we see in the liver in children usually occur in the neonatal age group, giving rise to severe cardiac failure. I will show you examples of these and what can be done. Sorry, I just want to go back to this slide. So what can these infantile hemangiomas in the liver do? Well, I said they may be asymptomatic and eventually self-limiting. They can cause cardiac failure, liver failure, associated with hypothyroidism. Some of these children have elevated TSH levels and they need massive doses of thyroxine to improve the situation. They can get abdominal compartment syndrome. They can even die. Most are small, self-limiting lesions that we really don't need to worry about or ever intervene. In contrast to the neonatal AVM, these are never benign lesions in the liver. They cause heart failure, hepatic ischemia, portal hypertension, and death unless they are treated. There's a high mortality. There's a nearly 70% mortality even if they are treated of neonatal AVMs. So back, certainly the year before last, there's a large group at the Children's Hospital in Boston which proposed a classification for hepatic infantile hemangiomas. And they proposed this subclassification based on the number of lesions in the liver. And so these are lesions in infants, okay, and they proposed that to divide the infantile hepatic hemangiomas into focal when there was one lesion, multifocal when there are multiple lesions, and diffuse, I've actually got a CT, these are MRs and I've got a CT here, a diffuse when you really can't see much normal intervening parenchyma. So the entire liver is replaced by hepatic hemangiomas. This group with focal hemangiomas are thought probably to represent the congenital Riche type lesions. In my practice, we've differed in our thinking slightly, because if they were Riches, you would expect them, as per the natural history of a Riche, to regress by around 12 months of age, and we have 1 or 2 children where these have persisted till 5 or 6 years of age. These can cause cardiac failure. They may not cause cardiac failure. The multifocal hemangiomas may cause cardiac failure. They may not cause cardiac failure. It really depends, do they have shunts within these lesions. If the focal lesion causes cardiac failure, it's usually failure seen at the time of birth, whereas the multifocal is usually sometime later within the first few months. So that goes in keeping with the natural history of a Riche and the natural history of an infantile hemangioma. With the diffuse type, these are the lesions with the highest mortality due to the fact that they can cause a compartment syndrome. And they often do not have cardiac failure, they often do not shunt, but a few are said to. And in fact, this is a picture of a baby, in fact an infant who was several months of age with an abdominal compartment syndrome, ended up ventilated because of respiratory compromise, because the diaphragms were splintered and displaced by the massive size of this liver, which was completely replaced by hemangiomas. When you see a patient who has multifocal lesions like this, if you actually go and look at the patient, and you see, for example, with multiple skin hemangiomas, in cardiac failure, having to be ventilated, for example, because of severe cardiac failure, without even looking at a scan of the abdomen, if you were to guess what was the problem, you would probably be right that there's no congenital heart disease and that there are intrahepatic hemangiomas. If you have more than 5 cutaneous hemangiomas, it increases your risk of having an intrahepatic hemangioma.